Okay, excellent. So I've been asked to talk about the chronic debilitating disease of cardiovascular disease. And I must reflect that we really are talking a lot about reproductive issues. And so I'm delighted to talk about something that actually kills more women than anything else and is also a major source of morbidity. Next slide. So we'll talk about the leading killer of women. We'll talk about what we do know. We'll talk about what we do not know, hopefully setting the stage for filling critical knowledge gaps. And then we'll end with what we should do about it. Next slide. Next slide. So I'm showing you a international plot, and why do we care about that when we're talking about the US of A? Well, what you see is the US of A in the blue is not as dark blue as other economies that are similar in terms of advancement, specifically Canada and Australia and Europe. And really underscoring what I think is a critical problem, and we are addressing over and over again today, which is our widened socioeconomic status gap, and that so much of these problems of either stagnant or rising rates are really in many ways the result of inadequate public health and access to healthcare. So next slide. This is US data, and the trends in cardiovascular disease mortality among women and men. We have been winning the war, as you can see on the right, that both male, shown in the blue, and female cardiovascular disease death rates have declined. But again, this would fall right on a plot of socioeconomic status. The rates are on the way up. And we are likely to see even more as the result of the COVID pandemic and lots of lost time in terms of deferred and delayed care, as well as risk factor management decline. We also see in the next slide, declines are less. Next slide. Oh, there we go. Just my arrows. When I don't drive, I get messed up. All right, next slide, thanks. Next slide. We're also seeing trends in young women that are quite alarming. This nice study from New York demonstrates that CVD mortality is stagnant for young women. Next slide, which is an arrow. Compared to men on the right, next slide, going down, young men, and next slide, the arrow going up in the female data is Black and brown women are actually incurring greater cardiovascular CVD mortality rates compared to young men that are Black and brown. So this is really, this is horrible, it's unacceptable, and it's happening in our country. Next slide. So if we talk then about what this congressional mandate wants us to do is really holistically look at causes of morbidity. And if we were to follow Dr. Bird's suggestion that we talk about return on investment, ischemic heart disease, as you can see, it just tops the list. So cardiovascular disease is the leading killer. It's also, as shown here in blue, the leading cause of disability adjusted life years. And so if we were really going to bite off something and make the most impact on our mortality, morbidity, and our healthcare costs, we really would tackle cardiovascular disease in women. Next slide. Yep, more arrows, sorry. Next slide. So let's talk about what we do know. Next slide. Advance, good. So I really do like the Office of Research of Women's Health strategic plan. Dr. Clayton has done an amazing job with Dr. Collins of leadership, talking about risk factors and disease modifiers over the life cycle. And what we've plotted here, of course, on the top are socioeconomic risk factors. I really think this is going to turn out to be something that we can really probably make an impact on, as well as having it with the sex and gender lens. So only women can get gestational diabetes. This is something that we've known for a long time predicts premature disease, and yet we really have no systematic approach to it. Only women uniquely can have other types of peripartum cardiomyopathy. But what we learn about that is we start to learn about other female, not specific, but female slanted cardiomyopathies, such as Takotsubo syndrome, which is increasingly being recognized and is both a contributor to lethal mortality as well as morbidity. Next slide. We know a lot about cardiovascular disease, and we actually know how to prevent it quite well. The risk factors for cardiovascular disease in women are well established. They affect both sexes. Notably, when the Framingham Heart Study was started in the 1950s, they had a separate study for men and a separate study for women. So even in the 1950s, we knew that we should be specifically looking at women. And what they demonstrated was in our well-established cardiovascular risk factors shown in the middle box: hypertension, dyslipidemia, diabetes, obesity, unhealthy diet, cigarette smoking, and physical inactivity. They're minor differences. And so if we just had a good public health and primary care approach to this, we would do a lot better. Of course, there are risk factors that are sex-specific in pregnancy. We've mentioned some of them. And these are, as opposed to the Holy Grail, these are an opportunity to identify risk in young women, which A, is a problem, and B, heretofore, we really haven't had very good tools. Next slide. Women have more chronic conditions as well compared to men. And if you look at chronic conditions that we have both the knowledge and the technology to deal with them, such as the top one, hypertension, such as the second one, hyperlipidemia, such as the third one, ischemic heart disease, and the fourth chronic condition, diabetes, it's really kind of shocking that we can't do that. Because these diseases are well phenotyped, we understand mechanistic pathways, and we have good medications, we have good drugs. But it turns out drugs don't work in people that don't take them or don't have access to taking them. Next slide. What do we know about our strategies for treating and preventing cardiovascular disease in women and men? Next slide. No, hang on. If you advance on that slide, it should pop up. Maybe we lost the title. Yeah, all right, it's not working. Go back, please. Thank you. The title will pop up and it says that basically these therapies listed on the left are all demonstrated to be equally effective in women and men. And this is good news in cardiovascular disease. Super good news. Next slide now. So one of the things that we have done, because in the Barbra Streisand Women's Heart Center, not only do we do the three-legged stool of clinical care, research, and education, but we put that seat on top of the stool, which is advocacy and policy. And so we commissioned this survey done professionally by the group listed here, GFK. And we wanted to survey American women as well as healthcare providers, primary care, OBGYN, and cardiologists about women's heart health, and just to get an assessment of knowledge, attitudes, and beliefs. Because if you were to embark on what you might consider a community campaign and a physician education campaign, you would want to know existing knowledge, attitudes, and beliefs. Next slide. So of course I can't spend too much time on this, but it demonstrated low public awareness. So the woman on the street still does not know that cardiovascular disease is their personal leading healthcare threat. We also found women reported a lot of fat shaming. They would put off going to the physician until they lost some weight. And indeed, physicians rank ordered weight management as #1 item in managing their patients. Shocking. Low system awareness, meaning the systems, our health systems are not set up to be trying to facilitate diagnoses and treatment that would have better impact in women. Low physician awareness. The physicians told us that they did not feel equipped with the appropriate expertise to diagnose and treat women's heart disease. And that there was a lack of physician education. And that just tells you, I mean, the physicians are being pretty honest, just like these community members, and they said that they would welcome better education. Next slide. So this is Kaiser Family Foundation data, and I just again want to mention the downstream of the pandemic. Since March 1st, 2020, women, particularly women in poor health, have been most likely to skip healthcare visits. They either skipped a yearly checkup or a routine test, or they skipped a medical test or a treatment. And this is the predicted tsunami that we are going to see as we hopefully close on this horrible pandemic with getting up rates of herd immunity. We will be dealing with a new epidemic of cardiovascular disease due to delayed and deferred care. Next slide. Please advance. Yep, thanks. All right, so let's move on. Next slide. What we do not know next. So what do we not know? Well, we've talked a lot about it today. We don't really know how to reduce avoidable morbidity and mortality and achieve equity in cardiovascular disease and these comorbidities in women. You can see that Dr. Leslie Shaw painted here what is the avoidable morbidity and mortality of CVD in women. And it's particularly true of diverse women, our Black and brown women, and again, in particular, our younger women under the age of 55. Next slide. And one of we paint here approaches. Yep, next slide. Oh, I have to take this off, otherwise it can't go. We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anyone. Next slide. So we do have a lot of knowledge gaps, and some of this was covered earlier this morning. The irony that male animals, and to this day continue to be studied for female disease. If you look at things that are more prevalent in women shown in the purple bars, and then show that the animals are dominantly male shown in the blue bars, it's got to change. This is a 2010, and we would like to think from some of the presentations we saw this morning that this is slowly changing. So we will remain optimistic, but we do have to put more teeth into those policies. I completely agree with that as well. Next slide. And what are the consequences of drug and device development? How do we improve human health by studying only male animals and male human subjects? This is data perhaps well known to many, but always bears repeating. Of the 10 drugs withdrawn from FDA approval between 1997 and 2001, 8 of the 10 were withdrawn due to greater health risks in women, demonstrating that if you don't test it in women and you don't develop it in female animals, you will have unanticipated adverse consequences due to these differences in physiology and metabolism and drug delivery. 4 out of 8 involved, it was prescribed at a higher rate to women, even though it hadn't been adequately tested in women. Another 4 to 8 were prescribed at similar rates in men and women. 3 out of 4 of those were withdrawn due to QT prolongation, a cardiovascular issue that is a lethal potential risk. And then 1 out of the 2 where there was no evidence of greater risk, but it was withdrawn because of this QT prolongation, which again is fairly easily measured and should always be incorporated. Next slide. Next slide. Good. Here's what else we don't know. We continue to not have journal editors require that the data be provided stratified by the sex of the animal or of the human. And what you can see here up through 2011, and this continues, that we don't require it, which is unfortunate because given the ability now to store digital supplemental files, these data really should be required. Thankfully, some journals like PLOS is requiring it. And so we can, again, hope to be optimistic, but it will require policy instead of preferred or should. It would be required language. Next slide. Next slide. So here's another example of consequences. I work with Dr. Jennifer Van Eyck, who does proteomic investigation, but also is a policy advocate along with myself and my faculty here. And she has worked with this ultra high sensitivity troponin. What's troponin? It's a biomarker. We measure it in the bloodstream. And when you can detect it, it means that there is injury, damage to the heart. And most often that's a heart attack. And as we know, if you don't get hospitalized for a heart attack, you have a pretty good chance of dying because we don't get to deploy those therapies that I showed work equally well in women and men. And what you can see from this slide on the right with the bell-shaped curves is that women and men, due dominantly to size, have different levels of troponin when there is a damage to the heart muscle. It's just size matters, turns out, in NASA spacesuits and in troponin. Next slide. And so these investigators, using a high sensitivity troponin test, were able to show that when you stratified according to women, you picked up a lot more heart attacks. So women were being sent home because they did not qualify for the male threshold of diagnosis of an MI. Let's advance the slide and see if my arrows come up. Yes. So this is back to the 1970s when I was training. When we would admit a heart attack, they had a 20% chance of being dead the next morning. My faculty cardiologist would put some oxygen in their nose and give them some morphine and pull the shade. And if they were there in the morning, we'd take care of them again. We didn't really have good therapies. And what you can see was that did not make a difference on the bottom in the men. The men were already being diagnosed because we use a male standard threshold. Next slide. Yeah, for women. Next slide. Yeah, and also it's nice to point out we will do better for smaller men. What happened to my title? All right, maybe next slide. Maybe the title will pop up. Nope. All right, go back. Sorry. So this actually was an article published in our leading cardiology journal, the Journal of the American College of Cardiology, when Dr. Jenkins was at the FDA Office of Research in Women's Health. And in their very nice systematic review, they demonstrated that in our most lethal cardiovascular disease conditions, acute coronary syndrome, coronary artery syndrome, and heart failure, all enclosed in the red boxes, you can see that women remain under-enrolled for FDA approval for therapies. Thank God women prevailed in pulmonary hypertension. That's one of the conditions that's rare in men. Was surprised it wasn't even higher. And so we really must be doing better, and a policy will make this better. Next slide. Here's another consequence and what we don't know. We continue to see higher acute coronary syndrome mortality in women. So here's contemporary data that despite, as you can see, the blue trend line is going down, we continue to have an excess of death in women compared to men. Next slide, my text box should pop up, very good. And the conclusion was women presenting with acute coronary syndrome, that's ischemic heart disease, are a high-risk population, and their in-house mortality remains higher for all age groups compared to men. Although substantial improvement in hospital outcome has been observed, guidelines adherence and improvement in the hospital care have not been optimized and won't be optimized until we take some action and do a better job with guidelines. Next slide. So next slide, what should we do about it? Next slide. So we formulated the Women's Heart Alliance. This is an umbrella organization, but sponsored by this collaboration and the Barbra Streisand Women's Heart Center. Next slide. And it really is asking us to all see this as a social justice issue. Our mission is to raise awareness, encourage action, and drive support for women-focused research and treatment to fight women's heart disease, the leading killer. Our goals are to empower women to take action to fight disease, engage doctors in improving diagnosis and treatment, and garner support for policy changes in women's heart disease funding. We need to demonize heart disease. Next slide. Our initial campaign was Fight the Lady Killer. Advance. Where is my text? There we go. Just keep advancing. Using a celebrity lead and a local campaign, we work to destigmatize, counter stereotypes with facts, increase risk factor awareness, and call to action. The action is to get heart checked. This is simple, using online scores. Anybody can do it. You don't even need a physician or a nurse. And it actually now works better in women and as well as our Black and brown women. And advocacy, similar to what we heard this morning, we spend 10 times more NIH and NGO funds on breast cancer research, yet cardiovascular disease kills 10 times more women than breast cancer. For those of you that are fans of the American Heart Association, they spend less than 4% of their Go Red philanthropic funds on women's cardiovascular disease research. So it's very lopsided. We're not putting our money where we should be, and we could certainly do a lot better. Next slide. Okay, so here's our challenge. Can we click on that link and see our PSA campaign? And I was worried it wasn't.
We may need to drop the link in the chat for time, but
okay,
we can do
that's
that.
fine. Okay, thank you.